particular skull, which of course we're looking at the calvarium from above, is a peculiar animal. And what you will find is that oftentimes skulls such as this are associated with a variety of genetic disorders. So that's not always the case. There are conditions in which, hydrocephalic conditions in which the normal development of the skull is disturbed in some fashion, and thus, as a consequence of the change in the conformation of the skull, the abnormal changes in the conformation of the skull, these Wormian bones and other bones will form. But you can see here, for example, a paramedian longitudinal suture, which you should very rarely ever encounter. You can see all of these Wormian bones that are present at various locations. These are more likely, when you have these in the anterior, or the close to the frontal bone, they're more likely to arise as a result of modifications or abnormalities in intracephalic pressure. But the rest of this is quite unusual. I just submit this as a curiosity more than anything else. All these Wormian bones and abnormal sutures. It is the case that as we age, the angularity of our cranial features tends to diminish. The bones, you can see, there's very little evidence of dentition here. The zygomaticus is sort of rounded, the superciliary ridges are sort of rounded. That tends to happen over time. What happened over here?
She was abducted by aliens.
Yeah, that's cranial binding. In case any of you find that attractive, then you want to go home and do that this afternoon. It won't work that way. This has to be done early in development. You can't do it at your age and expect not to have adverse consequences. Yeah, but this was thought it's been practiced by South American, Asian cultures long ago and fairly recently, and I guess it still goes on. But the idea was to suggest social status, also thought to be an expression of pulchritude of beauty. I think in most cases the implication is this type of skull shape is associated with the highborn, the nobility, and the attempt to reinforce that. Any adverse cognitive consequences? Would you anticipate? Most of the studies, it's difficult to set up a randomized controlled trial for this type of thing. But most of the studies find there are no really salient adverse consequences. Again, it's kind of hard to do even an epidemiological study.
Do you anticipate that because the brain conforms to the skull because it's done at such an early age? So it still functions?
Yeah, apparently. One thing that tends, if you'll notice, I'm not sure these two skulls are the best for this purpose, but intracranial volume doesn't seem to change very much. And then the signals that are used, the way that the neurons know where to project and so on, we don't have a very good understanding of that, but presumably, as you suggest, all of that signaling between these neurites and where they should end up is modified to be normal. We talked about the fontanelles and the importance of those in allowing the nervous system to expand the brain case developmentally. Again, there are a number of synarthrotic conditions and a number of genetic disorders in which the fontanelles close prematurely. And when that happens, you get something analogous to the cranial binding. The skull will be a little bit abnormal in shape. And then in that case, for whatever reason, if there's premature fusion of the fontanelles or the sutures, that often does have adverse consequences. If the brain case is not sufficiently large and there's no opportunity for it to grow, you'll have everything from exothalamus, bulging of the eyes that has to be addressed, to hydrocephalus, compression of the gray matter relative to the white matter, and all kinds of problems. Oftentimes, when that's caused by genetic factors, there are other associated problems as well. What is cradle boarding? Well, you can see the analogy in the shape of the head. This is where they would take the baby or the child in the neck and strap them. Mother would wear a little papoose or whatever on the back. And the surface of the carrier would be fairly hard. The child's head would be strapped into it. And just doing that on a day-to-day basis on a developing skull could have the consequences you see here. Again, in this case, there don't seem to be any adverse cognitive consequences. Of course, that brings up the whole debate about how should your baby sleep at night. Should you put your child on your back, on their back, or what are the considerations there? Sit, yeah. And so, but there is something called flat head syndrome from consistent sleeping of the child on the back of the head, like that, pressure on the back. Oh, we talked about the bones. As I've indicated, you really need to know certainly all the bones that are mentioned here. These are the facial bones. I'm not too concerned that you will be able to tell me if they're facial or not. I think in most cases that's fairly self-evident. There are a number of surface anatomical features that we've already mentioned to some extent that you need to be familiar with. The superciliary arches, again, they have a variety of other names, but that would be this region here, tend to be more pronounced in men than in women. The nasal bones, we talked about the nasion, the nasal bone. The glabella is again that region between the superciliary ridges. The zygomaticus, or the zygomaticus ramus or arch, also like the angle of the mandible, tends to be more pronounced and angular in males than females. The mental region down here, some individuals have a mental depression, some have a different term. Mental protuberance, so the term mental refers to the chin there. And a lot of these figures, I'm just pointing out things that you should be familiar with. I think we've talked about a lot of these. You can see the superciliary ridges in the skull very clearly. You can see the nasion and the glabella. You see the frontonasal suture that I was talking about here and how it tends to depress laterally, how it tends to drop laterally. This anterior opening to the nasal cavity is called the piriform aperture. Piriform just means pear-shaped. We can also see foramina. Foramina are openings, small openings. There is a supraorbital foramina and an infraorbital foramina. Both of these accommodate branches of cranial nerve 5, we'll talk about later. And often, usually in association with some vascular structures as well. Be able to, again, differentiate the bones. Mandible down here, maxilla here, zygomaticus here, frontal bone up here, nasal bones we've already talked about. There's reference to a zygomatic or facial foramina. That I think you can sort of see it right there. There's a little opening there. I think the proper pronunciation is foramen, but I just don't have the mental discipline to say that, so I just say foramen. But I think you should know that the proper pronunciation is foramen in American English. Another illustration of the anterior skull. I think most of these we talked about. Let me just point out a few other things that you should be able to identify in an image such as this. We've talked about the superciliary ridges. Notice here they're called the supraorbital margin and the infraorbital margin. So again, different terms for the same thing. We can see in the piriform aperture inferior to the nasal bones some components of the nasal septum. There will be two bony compartments, or two bones, and several cartilages associated with it. But this is the septum here, and we'll talk about the ethmoid and the vomer that contribute to the nasal septum. You can sort of see the piece of the bone right here, and this is called the perpendicular part or the perpendicular plate of the ethmoid. Ethmoid is a very strange, irregularly shaped bone, kind of like the sphenoid in that regard. The maxilla and the mandible, both of these have what are called alveolar processes, and in the anatomical literature, you will see this term, both singular and plural, referring to the same thing. So my point here is, if the monograph, if the journal article is talking about the mandibular alveolar process, that probably doesn't refer to just one dental socket, one gomphosis. It probably is referring to the whole range of them. But again, mandibular alveolar process and the maxillary alveolar process just refers to those sockets or gomphoses for the teeth, the dentition. Now, in this illustration, you see the orbital cavity here, the cavity to accommodate the eye, and you'll note that a number of bones make up that cavity. What I would ask that you begin thinking about, begin doing it, I think you probably need to see more illustrations that are shown here, and we'll look at an ACLID video in just a moment. This portion of it to help us with that. But you should be able to identify all the bones that are present in that orbital cavity. And so at the back there, it's usually called the wall, but it's really almost the posterior region. In addition to the bones we talked about, this would be the sphenoid bone. That reddish bone is the sphenoid. And then associated with that, you see a number of little fissures, such as the superior orbital fissure here between the frontal bone and the sphenoid, right in there. And those are going to be important because later we'll find that critical neurovascular structures pass through those fissures and foramina. We've indicated, we talked about the turbinates and the concha. You sort of see those there. Remember, there's 3 on each side, and their function is primarily to contribute to the, they'll increase the surface area over which the incoming air flows to warm the air, to filter the air, humidify the air. And I think that's about all I see. The only other term here that maybe we should pay attention to is the term genu. An individual may or may not have a mental genu of the chin, but this term is a general anatomical term to refer to any angle, any flexion. For example, the internal carotid artery is said to have at least one genu. We'll talk about other structures that have a genu. The notion is flexed knee, but it just means a bend or angularity to the structure. Now understand, when I was talking about you're responsible for everything on the slides, we're talking about the physiology course and some of the physiology tests. It doesn't apply so much in here. I'm not going to ask you to identify all the structures that are indicated here. But in an illustration like this, what you should know is that I may, on the test, give you this illustration without the labels, of course, without the lines and the labels, and ask you to label or denominate or identify some of the structures we've talked about already, such as the maxillary and mandibular alveolar process, the piriform aperture, the conchae. You should be able to point out the zygomaticus, the sphenoid bone, frontal bone, the Nazian, and so on. Right? So just make sure that when I give you an illustration like this, it's not so much that you be able to identify all the various components, but this might well be fair game for the test. Yeah.
Does the sphenoid bone make up kind of like the back of the eye socket?
Again, I would agree with that characterization. In most anatomical texts, though, the term you see is wall of the orbit. Yeah.
And it's like one bone covers both.
No. There's well, yes, you're right. There's one bone that, if that's what you're saying, the sphenoid. I didn't know. The sphenoid, yeah, extends all the way from the temporal region down here. It's a very curious one. We're going to spend some time looking at it because it's so critical. In fact, we're going to look at a little ACLID video on the sphenoid. So you know what the pterion is, you know where to identify that and why it's important anatomically. What this slide is showing in addition is a region called the temporal fossa. I think we mentioned this before, the temporal bone there. Temporal fossa, a number of important neuroanatomical structures and vascular structures passing through there. We'll look at it a little later. Here's the external acoustic meatus. Here's the zygomaticus. And then under that, here's the temporal fossa here. And then under that is called the infratemporal fossa. So this would be the infratemporal fossa, especially if we were to move that ramus. By the way, the external acoustic or auditory meatus is just your tympanic canal there. There's an internal acoustic meatus. The two are unrelated. And so I'm giving you very explicit instructions here to be able to identify the temporal fossa in a graphic such as this. And you can see the infratemporal fossa down here. Mastoid process here, the external acoustic meatus. We've already talked about the styloid process being an important muscle attachment for a number of muscles of what are called the suprahyoid muscles here in the neck. A couple of those go right back to that muscle we'll find, or that bone we'll find later. So be able to identify those structures. Some of these others, we are going to sort of simplify this. But this region in here is also important, once again, because of a number of the critical neurovascular structures that pass through it. But I'm going to use a somewhat different or simplified terminology. This is not a terribly useful graphic, except it does tell us, when we're looking at the lateral cranium here, we're looking at the zygomaticus has been removed. You can see there's a portion of the end of the thing. So these are some of the contents of the infratemporal fossa. So that would include portions of the temporalis muscle there. These are branches or the efflorescence or the reticulation of the external carotid. This is the external carotid here, so it passes through it. The portions that we'll talk about, including the parietal, frontal, auricular arteries. There are branches of the cranial nerve 5 down here as well. So it's a very busy region. You can see the pterygoids. These are muscles of mastication, innervated by cranial nerve 5. We'll talk about these a little later. So it's a very busy area. Should know the basic dentition. Anterior and lateral incisor, canine, 2 premolars, and at least 2, sometimes 3 molars. Looking at the mandible here, and you can see the mandible has a curious shape. Here's the angle of that. Here's the mental region down here. But notice at the joint itself, there are 2 prominences. There's the condyle and the coronoid process. The condyle back here and the coronoid process here. The coronoid process is anterior, but is exclusively for the purpose of muscle attachment. The condyle itself is the actual pivot of the mandible. And then between the 2 is the mandibular notch. So we're looking at the mandible from the inside here. Once again, you can see the denomination of the dentition. You can see the anterior coronoid process, the posterior pivot or condyle. And then you have a couple of other interesting features. You have this little canal in the bone that's primarily there to accommodate branches of the, once again, cranial nerve 5. At this point, it's called a couple of small nerves, the alveolar and the mylohyoid. Oftentimes, when the dentist sticks his needle to numb your teeth, he's shooting for this region here because he's not going to be able to access, or she, shouldn't sound sexist here, they're not going to be able to access the nerve in here. So oftentimes, and that usually will afford at least some anesthesia for the anterior region. Usually they have to, depending on the procedure, anesthetize additional nerves as well. Also of interest here is something called the mylohyoid line. That's a little ridge for muscle attachment. The muscle in question is the mylohyoid, which is this muscle right here that forms the floor of your chin. So we've talked about the external occipital protuberance that prevents you from resting your head comfortably on a hard surface. Either wants to roll one side or the other. We've talked about the nuchal lines. There are usually two of these in most of us, sometimes three, superior and inferior. So the superior nuchal line here, the inferior nuchal line here, these are both ridges for muscle attachment. And generally demarcate, strangely enough, these nuchal lines, formally at least, demarcate the posterior boundary of the neck. That's the point where we go from the neck to the head, at least in a formal anatomical sense. And we've indicated that lambda is the junction of the sagittal and the lambdoid sutures, and oftentimes there will be a little depression in the skull there in many individuals. We can see again, the sagittal. We can see the lambdoid suture here. We can see the inion. We can see the two nuchal lines. Remember the reference to Wormian bones. They would be present usually in here somewhere if they're present. Here's the occipital bone, both from the inferior and superior perspectives, characterized by the foramen magnum, through which the spinal cord, at this point, the brainstem, passes. And you can see its anatomical position there. So I think we've talked about all the structures in this plate. You shouldn't have any trouble identifying those. I would point out on the lower right graphic here, we do have some terminology to describe the organization of the flat bones. Remember, when we talk about the longitudinal bones, we talked about the compact bone and the medullary and sometimes cancellous bone. And this bone, which has this bone does not develop by endochondral ossification. It develops by a process called inframembranous ossification. But you have at the perimeter of the bone, the periphery of the bone, paired compact regions, sometimes called the internal table. But here's what we want to focus on. This interior region here is called the diploe. Diploe. Don't know if you can see that word or not. D-I-P-L-O-E. And the reason that's anatomically important is we'll be talking about diploic structures later, and so you really need to know what we mean anatomically, where they're located. Be sure in this illustration you appreciate what we're looking at. This is the calvarium, except we've taken the calvarium, we've removed our calvarium, now we're looking at the inside of our calvarium from below. So in other words, this is the inside of the top part of the skull. And there are several features you want to pay attention to here. Notice there in the calvarium, well, first of all, you see these reticulating lines. There are not going to be any blood vessels in this bone like this. Those are the ridges or lines that accommodate the meningeal vessels of the dura mater. And so as the skull develops, there are just little impressions left in the skull from those dural vessels. The other thing you'll notice, though, is this sort of linear arrangement of ridges along this sort of plane here. And that's going to be very important to our discussion to follow, because that system of ridges is associated with the way that the dura mater, remember the dura mater is the outer layer of meninges, attaches to the calvarium. So you can see the frontal crest there, the dura mater, the attachment of the dura mater. It's going to extend toward us, in this particular representation. It would extend toward us, forming something called the falx cerebri. Which we'll see in more detail later. This is a large plane, a large flat region of dura mater that separates the two hemispheres of the brain. Falx just means crescent shaped. And so what I'm saying is we're going to have a long flat sheet of dura mater that's projected toward you from this point. Now, as we move posteriorly from that frontal crest, notice that the line sort of separates here. I can draw to it. And that's because at this point in the skull where the dura mater is attached, the dura mater separates. So there's going to be a flat surface running attached very closely, attached very precisely to the surface of the skull. But then another portion of it is going to come down like this to form the falx cerebri. And then through that little triangle, through that little partition, it's actually called a sinus, is going to be a very large volume of venous blood. It's called cranial sinus. But in any case, what you can imagine, I'm trying to think of an analogy, it's like a little tent, a little pup tent. And here's going to be the top of it coming at you like this. And then the dura mater sort of flattens on either side. And a number of things happen there. There's going to be venous drainage of all the blood that circulates through the skull. A lot of it's going to aggregate in this region. But there are chambers in your brain that contain another kind of fluid. Do you remember the type of fluid that's contained in the brain? Yeah, cerebrospinal fluid. And what we're going to find is that that cerebrospinal, the volume of CSF has to be precisely regulated. And these little depressions, these little indentations here are structures that contribute, we'll talk about them more later, that contribute to the regulation of CSF volume. But it's rather remarkable that we can see impregnated in the skull the soft tissue that is responsible for regulating the CSF volume. They're called arachnoid foveolae or granular foveolae. And we talked about the laminar organization or laminar structure of the cranial bone. You should also be able to identify the structural fossa. Now, again, get your bearing here. Make sure we're looking at the basic cranium from above. We're looking at the floor of the skull from above. We're no longer looking at the calvarium. This is the floor of the skull. And you can see colored or indicated by the colors there are the anterior, middle, and posterior fossa. The red is the anterior, the yellow is the middle, and the green there is the posterior. By the way, there was an error in your slides, and I've corrected it, so you can correct it too. For some reason, the word of the paired temporal bones was left out. I'm not sure why. That's what I saw. Did everybody see that? So add that to your. These are the bones that make. So when you look at the floor of the skull here, is another illustration, I think. So, for example, we can see the parietal bones here, right? The temporal bone here, occipital back here. Here's the sphenoid and frontal. So just make sure that you understand that all of these bones are present. Yeah. So in other words, they're all the little colors here indicate the bones. So you can use both of these. I just noticed that that was missing. Now, as you look at this very simple illustration, remember these are fossae, so they're going to be depressions. What's going to be resting on the posterior fossa? Anybody know? Yeah, the cerebellum. So just be aware that the cerebellum would be, the lobes of the cerebellum would be sitting back here. What would be resting, what portion of the brain would be resting on the middle fossa? Anybody familiar with that? The temporal lobes, these large lobes that are important for hearing and processing sound, some other functions. And logically enough, what's going to be resting on the frontal bone? The frontal lobes, yeah. So just be aware of that general organization. And you can see the sphenoid then, what we call the lesser wings of the sphenoid, sort of separate the frontal bone from the sphenoid. Again, the red is the sphenoid here, sphenoid ridge. And this margin out here is the parietal bone. Looking at a very similar sort of thing here, except what we're looking at includes portions of the dura mater. Remember, the dura mater is going to be firmly pressed up against the wall of the skull. We're going to go over this in more detail later. But so what we're looking at is the floor cranial base with the dura mater intact. And so the dura mater is overlying the frontal bone there. We can see it overlying a portion of the middle cranial fossa. But back here in the posterior fossa, you have a flat portion of the dura mater that separates the cerebellum from the occipital cortex. And that's called the tentorium. So I just want you to appreciate, as we look at this illustration, here's your cerebellum down here. And the cerebellum is going to rest on top of the posterior fossa here. And then we have this flat sheet of dura mater here, this glistening sheet. And then on top of that, superior to that, would be the occipital cortex. This just gives us a few additional features. What I was really pointing out here in this illustration, which is a busy illustration, I wanted you to see the relationship of this to this. So you've removed the brain of the patient for whatever reason. I'm sure it was for a good reason. You remove the brain of the patient because they're having eye pains, and you want to inspect the ocular socket. Now, this purple region up here, what is this purple bone up here? What is that bone? The frontal, okay, that's what I want to make sure you understand. The frontal bone is not just this bone. So the frontal bone, the little surfaces that you see here, overlie what? If I want to access the eye, how do I do it relative to the anatomy we're looking at here? What would I have to do? I want to find out why the eye is hurting. All right, so I have to go in that direction. What I want you to understand is there are no eyes up here, and that frontal bone is overlying or covering the eyeball, such that if you wanted to access the eyeball from this point, you have to get a little hammer and chisel and remove portions of which was what you do if you had a cadaver. That's what is routinely done. It's quite a messy business. All right, that's the frontal bone. Make sure you appreciate that aspect of it. And the other curious thing about this anterior region here is that while this is frontal bone and this is frontal bone, this is not. That central region there is ethmoid bone. And that's the little portion of the ethmoid bone that is associated with your olfactory sense. The little ridge there that projects up, the little ridge of the ethmoid is called the crista galli. And we don't see it very well here, but on either side of that little ridge called the crista galli of the ethmoid, there are little holes, little pinprick holes. And through those holes are the bipolar cells. When we talk about bipolar neurons are associated with the special senses. But through those little apertures on either side of the crista galli, through what's called the cribriform plate, extend the processes of the bipolar neurons that enable you to detect odors. You probably know I find this literature all equally depressing. All the literature devoted to aging really depresses me. But one of the most important premonitory signals of dementia is what? Loss of smell, progressive loss of smell. There was just another study last week reinforcing that. So here's the frontal bone again. Here's our sphenoid. And we need to talk about this region right here. Boy, this is a busy region. When I drew that circle, that's a very busy region. We need to spend a lot of time talking about that. Again, the occipital bone back here. Again, on the lateral side, you have the parietal and the temporal down here. But I just wanted to make sure in this illustration that you saw the relationship of the frontal bone to what we're looking at here. And of course, the frontal bone that we're looking at is right there. I'm sorry. It's late in the day for me. I've been up. Here we are. There. Anything else we need to talk about here? We'll talk about, I'll give you a list of the foramina that you need to be able to identify as well in just a moment. We've already seen the palate. The palate, we've indicated, consists of two important bones, the maxilla up here, and then the palatine or palatine bone back here. And then there's a glottomaxillary suture between the two right here. But most of the hard palate is formed by the floor of the maxilla there. And you can see the suture between the paired bones. This would be the intermaxillary suture, interpalatine suture. Other ways we look at this, we can also see the posterior-most regions of the nasal cavity. Here, these openings, you have a slide coming up. They're called choanae. Once again, the choanae are these large openings right here on either side of the nasal septum. Again, maxilla palatine here, choanae there. What are the structures? Of course, you can see the dentition. You can see the maxillary, the zygomaticus. You can see this is called, it goes by a variety of names, sometimes called the pharyngeal skull, because this is where the pharyngeal, sometimes called the pharyngeal tubercle, because this is where the pharyngeal muscles that surround your esophagus are attached to the skull. You see the occipital condyles here. Again, condyles rest upon the pillars of C1, the atlas. And there are several of these foramina that we'll talk about later. There's a reference over here to the incisive fossa and the incisive foramina. That's right here. And there are a number of small neurovascular structures that pass through that little opening. Talked about the palate. We've talked about the pharyngeal tubercle here. We've talked about the occipital condyles. If there's a cleft palate, it's usually some malformation or insufficient closure of this intermaxillary and interpalatine suture that we talked about. Foramen magnum. At several points, I've made reference to the nasal septum. Here you can see the bony portion of the nasal septum, the perpendicular plate of the ethmoid, the vomer here, and then anterior to that would be several species of cartilage. You can see what's called sometimes called the septal or vomerine cartilage here, and then anterior to that is alar cartilage. So as you look at this nasal septum, several things. This is it's useful to begin putting some of these things together. So here's the nasal septa. They separate the two choanae or nasal passageways. The nasal vestibule again would be down here. This would be your choanae on a plane of section like this. Here's the sphenoid bone back here. So here's the nasal passageway. Here's the sphenoid. That's going to be important to keep in mind later. Keep in mind that basic anatomy because that's critical for a number of surgical procedures. So here's the sphenoid. This is sometimes called the cube of the sphenoid. Posterior to that is a portion of the occipital bone, usually called the basilar portion. Here's our septum between the oral and nasal cavities again. The maxillary and palatine portions. And then you can also see some more of these sinuses. In addition to this large sphenoid sinus cavity, you have a frontal sinus here in the frontal bone.
I'm not following how that basilar part of occipital bone, the occipital bone or the back of the skull occipital bone?
Yeah, this is the
Comes all
base.
the way up
Yep.
that far? Okay.
There's a little suture there. We'll see that, I think, a little clearer in just a moment. It's hard to see here. And then there was a question earlier about the nature of the sphenoid. And so here you go. This is the sphenoid here, just a very complex creature consisting of three general components, the greater, lesser, and pterygoid wings. So this would be the greater wing of the sphenoid up here, extending all the way from the temporal down to the midline of the basic cranium. And then that's the greater wing. We really don't have a very good view of the lesser wing here because they're on top. But these are the pterygoids here. Pterygoid just means wing-like, shaped like a wing. And the pterygoid process that you see extending inferiorly there, entirely for muscle attachment. In fact, you could probably guess what muscles attach to these pterygoid wings. What do you recall from your earlier study, the muscles of mastication? Yeah, the pterygoids, yeah, they're going to attach there. You can see the choana again. You can see the maxilla and the palatine bones as well. But as I say, this is a very critical region. There's a dancing sphenoid for your amusement. But we're looking at the back from the back perspective here. The lesser wings are on top. These are the lesser wings here. Here are the greater wings. These are the ones that zip up, go all the way up to the temporal bone there. And then the pterygoids extend inferiorly. Pterygoid processes extend inferiorly. Now, in looking at this thing in situ, we have a better picture, well, on the other side. This is what we need to pay attention to right here, because from the superior view, there are a number of critical structures. We have, in this region, we have endocrine structures, we have the carotid artery, the internal carotid artery, we have a massive blood sinus, cavernous sinus associated with this. Right back here is the trigeminal ganglion, cranial nerve 5. Coming right through here, and then wrapped around this is the optic chiasm. It's just a very, very busy region in which a lot of things can go wrong. And when one thing goes wrong in this region, it often affects multiple systems. So we're going to spend some time talking about this area. So here's the sphenoid again from the sagittal section. Is it any clearer to you why this would be the occipital bone? And so again, the two portions, the two bony portions of the septum. Once again, here's our sphenoid sinus. Again, the temporal and occipital bones there. Here's what's sometimes called the temporal or the greater wing of the sphenoid, pterygoid down here. Sometimes called this little projection down here is sometimes called the sphenoid spine, sometimes called the sphenoid annulus. But in either case, it's a critical point of muscle attachment. And then here's the styloid process back here unrelated to the sphenoid. We pointed out earlier that the sphenoid is present in the posterior wall of the orbital socket. And once again, these fissures are going to be very important because they allow critical structures to pass through. Now, here's the cube of the sphenoid, right? Here's the sphenoid sinus here. Here is the nasal septum here. And so now we're going to direct our attention to this structure right here. We were looking at that structure from above just a moment ago. This is called the Turkish saddle or the sella turcica. And that little cavity or the depression you see there encases the pituitary gland. The hypothalamus is going to be up in here. There's going to be a little stalk, and then there's going to be the pituitary gland encased by the bone of the Turkish saddle or sella turcica. So, if you tonight want to inspect the health of your pituitary gland, what's the best way to get to it?
Nose?
You want to go in through the mouth. All right, you'd have to cut through all of this. Can you think of even a quicker way?
Through a nose?
Yeah.
Is that
Boom. There's your sphenoid sinus, and there you go. Just a little bit of bone, and that's it.
what the procedure in the past was called phlebotomy? Is that what is
A
Relate-
what type of
phlebotomy? Or
lobotomy?
lobotomy? Yeah.
No. Phlebotomy isn't.
Right. Lobotomy.
No, that's up here. We'll do that later if
Okay.
you want to. Somebody bring an ice pick. We're going to need that. It doesn't even have to be sterile. No, we're going to actually, I think, have a video. We'll look at some pituitary surgery to see how this is done. It's quite gross, actually. So we'll enjoy that a little later. This is a Lackland video. To give myself a break, I think this is a short one. I often use the Ackland segment, so we'll finish up today with with Ackland's discussion.
Here's the back of the hollow part of the maxilla. Down here, the maxilla is joined to the bone behind it, the sphenoid bone. Apart from this attachment, the maxilla is separated from the sphenoid by this impressive cleft, which has a vertical part and a horizontal part. The vertical part of the cleft is called the pterygomaxillary fissure. The horizontal part of the cleft is called the inferior orbital fissure. The inferior orbital fissure, here it is from in front, separates the floor of the orbit, formed by the maxilla, from the lateral wall that's formed by the sphenoid. Now we'll move on to look at the sphenoid bone. The sphenoid bone is extremely complex. It extends all the way from one side of the skull to the other. The sphenoid bone forms important parts of the underside and outside of the skull, and it forms part of the orbit. The sphenoid bone also forms this large and complicated part of the floor of the cranium. Here's a sphenoid bone all by itself. The sphenoid bone has a central part, and on each side, three major projections: the lesser wing, the greater wing, and the pterygoid process. The central part of the sphenoid includes the clinoid processes.
And that's important. What I want to point out here, because I'm not sure it's quite evident in your other illustrations, very quickly, these four projections, they're kind of hard to see back here, but these four projections are the clinoid processes, and these form the skeletal framework for that endocrine system, the hypothalamus, pituitary stalk, and the pituitary gland, which is going to rest right in here. Clinoid process. I think if I do, maybe let me finish this, because I'm afraid if I go to the other screen, I'll lose the video.
And the pituitary fossa. The central part of the sphenoid bone is hollow, as we'll see. The lesser wing, which is the highest part of the sphenoid bone, forms the sphenoid ridge, which separates the anterior and middle cranial fossae.
Anterior, posterior.
The underside of the lesser wing forms this small but important part of the back of the orbit. The greater wing of the sphenoid forms the front wall and part of the floor of the middle cranial fossa. On the outside, the greater wing forms this part of the temporal and infratemporal fossae.
which we looked
and
at
it
earlier,
also forms this large part of the lateral wall of the orbit.
and the inferior fissure.
The greater wing and the lesser wing are joined here, but more medially they're separated by this triangular gap, the superior orbital fissure, which forms a large opening between the orbit and the inside of the cranium. Here's the superior orbital fissure from the inside. We'll get a better look at it in a minute.
All right, before we leave, let's, let me go back to this quickly because I'm not concerned about all of this. Very quickly, what is this bone here? The ethmoid, and you're looking at the cribriform plate there.
Here's the superior orbital fissure from the inside.
All right, that's good enough. Somebody was asking about clinoid processes. There are 4 of these, anterior and posterior, and we'll talk about their importance at our next meeting. All right, so have a good weekend. I know that's not intended to be sarcastic.